Okay, so we are going to discuss about the examination of gastrointestinal tract and abdomen. Okay, and so how we are going to do it is we are going to divide the entire thing up into 7 segments. Right? So first thing that we'll talk about are the prerequisites, and then we will talk about the general physical examination related to the GI system, gastrointestinal system, then inspection of the abdomen, then comes the auscultation of the abdomen, then percussion, then comes the palpation, and finally we'll talk about some final considerations before we end it. Okay, so now starting with the prerequisites. What are the prerequisites that we need to fulfill before we touch the patient or before we examine the patient? Okay, so the prerequisites are that first I need the instruments. Right? So instruments is a must. So I have a torchlight, stethoscope, measuring tape, and a pen for marking. These are all the instruments that I need to perform the examination of GI system and abdomen. I am standing on the right side of the patient. Right? So this is a convention. This is a must. Then I am going to greet the patient, say namaste or namaskar. Right? So I am going to greet the patient, then I am going to introduce myself, then I am going to explain what I am going to do and how I am going to do it. So after I explain it, then I can take the informed verbal consent from the patient. Right? So I have taken that, and after I have taken the consent, I will offer to have an attendant present during the examination. I must offer to have an attendant present during the examination. Then I will maintain that the room is as private as possible. It might not always be possible, but I will try to maintain privacy. And then I will try to ensure that the patient is comfortable. Right? So the patient should be comfortable while you are examining it. And then after that, I will ensure that the room is warm. If there is a heater, I will turn on the heater. And I will ensure that the room has adequate lighting. So, and then I will ensure that my hands are warm, because I am going to touch the patient with my hands. So I need to ensure that my hands are warm. And then I will need to perform hand hygiene protocols. I will need to wash my hands. I will need to sanitize my hands. I will fulfill all of those. And then after that comes the 2 prerequisites, positioning and exposure. So those prerequisites depend upon the specific examination. I will talk about the positioning and exposure for abdomen examination when we talk about the abdomen. Okay, so these were the prerequisites. Now I will start with the general physical examination related to GI system. Okay, so I will start with the general appearance of the patient. So this patient, our enthusiastic volunteer, Mr. Sagar, is moderately built. I would say that he is moderately built, and he appears well, and he is well looking and moderately built. So that is about the appearance and the build. Okay, and then after that I will proceed with examining him from head to toe. So first I will examine his eyes. Right? In his eyes I will examine for pallor. Okay, so what I will do is I will gently pull down his lower eyelids. So I am looking for pallor over the lower palpebral conjunctiva. And then I will look for icterus. How I will do that is I will gently pull up his upper eyelids, and then I will ask him to look at my finger. If you could please look at my finger, and then I am examining for icterus over the upper bulbar conjunctiva. Okay, so these are related to the GI system. So that is why I am examining them. Then I will move on to the mouth. It is an important site for general physical examination, as well as it is a part of the GI tract. It is the beginning part of the GI tract. So it has a twofold importance. So to examine the mouth, I will need a torchlight, and I will ask Mr. Sagar to open his mouth, and then I will inspect the entire oral cavity and pharynx, and then I will ask him to turn over his tongue, and I will inspect the undersurface of the tongue. Okay. So specifically what I am looking for is I am looking for any cheilitis, that is inflammation of the lips, or angular stomatitis, gingivitis, glossitis. So these all are features of vitamin deficiencies and mineral deficiencies. So I am examining for those. And also I am examining for any lesions inside the mouth and the pharynx. Sometimes patients have these vesicles, sometimes patients have ulcers. So also inside the mouth I am examining for pallor over the dorsum of the tongue. and icterus over the ventral aspect of the tongue. Okay, so this all I will examine in the oral cavity. Okay, after the oral cavity, I will move on to his hands. Okay, so for his hands, I will look at the palmar aspect of his hands first. So I am examining for any pallor and any icterus. Then I will ask him to turn over his hands so I can examine the dorsal aspect. And I am looking for pallor over his nail beds. And I am also looking at the shape of the nails. I am looking for presence of koilonychia and leukonychia, which are all features of mineral deficiencies. And next I will lift up his hands and bring them to the level of my eyes, and I will tangentially look for clogging. I am looking at the onychodermal angle. Okay, so our patient Mr. Sagar does not have any clogging. So after hands, I will move on to the feet. To examine the feet, what I will focus on is I will focus on looking for edema. So if Mr. Sagar could please slightly lift up his trousers and pull down his socks of both his feet. Okay, that's fine. So I will look for edema above the medial malleolus, 2 centimeters above the medial malleolus, over the shin bone, over the tibia, over the bony prominence. So I will press for about 30 seconds, and after 30 seconds I will lift off my finger, and then I will palpate for any dimpling or for pitting. Okay, so that is what I will do. So ideally we should examine for pallor and icterus over the feet as well. Okay, so with that, our general physical examination related to GI system is complete. Okay, so next I will move on to the inspection of the abdomen. Okay, so for this I will need to maintain positioning and exposure. So I will ask our volunteer Mr. Sagar to lie down on the bed in supine position. So while maintaining positioning of the patient, how we will position the patient is, we will maintain that the knees are flexed, the soles are flat on the bed and the knees are flexed, and his upper limbs are by his side, and we will rest his head on a pillow. Okay, so this is the proper positioning. Okay, so this ensures that his abdominal muscles are not contracted during the examination. Okay, so next for exposure, we will ask our patient Mr. Sagar to lift up his shirt, and exposure should ideally be from xiphisternum to the mid-thigh, ideally, but considering the privacy concerns of the patient, it's fine to expose from xiphisternum to the symphysis pubis. So we are recommended to expose till mid-thigh so that we can examine the inguinal and scrotal regions properly, but considering privacy concerns, it's fine to expose up to the symphysis pubis. Okay, and then while inspecting the abdomen, what I am going to do is I am going to inspect his abdomen from all sides and all angles, from his right side, left side, from the head end of the bed as well as the foot end of the bed. So that is what I should do, and I should inspect from all angles to ensure that I do not miss any significant finding. Okay, and then I will also inspect tangentially. So how I will do that is I will squat down and inspect tangentially over the abdomen. So I am doing this to appreciate the fine movements of the abdomen. Okay, so next what I will look for during inspection is, first I will look for the overall shape or contour of the abdomen, and in our patient the shape is rounded or flat, which is a normal shape of the abdomen. Sometimes it can be distended. It is distended in patients with ascites or bowel obstruction. So those are causes of abdominal distension. And the shape of the abdomen can be scaphoid or curved inwards, and that happens in patients with malnutrition or in children with congenital diaphragmatic hernia. Okay, so those are all different shapes of the abdomen, and we need to notice and report the shape of the abdomen. The next thing that I will notice is the umbilicus. So in our patient, the umbilicus is central and inverted. So in patients with ascites or abdominal distension, the umbilicus can be everted. Okay, so next I will move on to the flank fullness. So in our patient, flank fullness is absent. If present, flank fullness may indicate the presence of, again, abdominal distension or ascites. Okay, next I will report the movements of the abdomen. So in our patient, all quadrants of the abdomen are moving correspondingly with respiration and symmetrically. So that is about the movement in relation to respiration. Then we will move on to report about the visible peristalsis and visible pulsations, whether they are present or absent. And we will report about them. Then we can report about the visible distended veins, visible scars, and the visible discolorations. So visible veins can be present in patients with chronic liver disease and in patients with vena cava obstruction, and scar marks can be present in patients with previous wounds or previous surgeries, and then discoloration can be present in patients with bruises over the abdomen. So if the bruise is present over the umbilicus, it's known as the Cullen sign. If the discoloration is present over the flanks, it's known as the Gray Turner sign. So those are all discolorations. Okay, so after I've done with all of this, what I'm going to do is I'm going to ask my patient to turn over on his left side so that I can inspect the back. So I will inspect for any spinal deformities and for the presence of any scars or any visible veins. So after I've done that, I will ask my patient to again be on the supine position. So now we are completed the inspection of the abdomen. Now we move on to the next part, the auscultation. Why we are auscultating the abdomen first is because if we palpate first, then what happens? We manipulate the abdomen. So we artificially increase the frequency of bowel sounds. Manipulating the abdomen will increase the frequency of bowel sounds. So that is why we want to auscultate first so that we can report the actual findings. Okay, so for auscultation, we need a stethoscope. And first we will auscultate for bowel sounds. So for bowel sounds, I am going to use the diaphragm of the stethoscope. And I am going to auscultate at a point just towards the right of the umbilicus. If you could come a little bit closer and show it. So I am auscultating just towards the right of the umbilicus, and I am listening for bowel sounds. So, and what happens is, I am going to appreciate normal bowel sounds which are gurgling in character and occur about once every 5 to 10 seconds. So about 6 to 12 bowel sounds per minute. So that is the normal frequency. And so if I do not hear any bowel sounds, then I need to listen for a complete 5 minutes before I report that there are no bowel sounds, because sometimes bowel sounds may not be heard at some places. So I need to listen for a full 5 minutes before I report that I did not hear any bowel sounds. Okay, so that's about the bowel sounds. And absent bowel sounds or decreased bowel sounds are features of peritonitis. And increased frequency of bowel sounds are a feature of acute gastroenteritis or bowel obstruction. And if you appreciate a tinkling character of the bowel sounds, that is also a feature of bowel obstruction. Okay, so next I will listen for brutes. So I will listen for brutes at 3 locations. The first location is just above the umbilicus. So here I am listening for aortic brutes. Next location is 3 centimeters lateral to and superior to the umbilicus on either side. So on the right side and on the left side. Here I am listening for renal artery bruise. And next location is just below the right postal margin in the mid-clavicular line. So here I am listening for hepatic bruise. Okay. So aortic bruise are present if the patient has abdominal aortic aneurysm or atherosclerosis of the aorta. Renal artery bruits are present if the patient has renal artery stenosis or atherosclerosis of the renal arteries. And hepatic bruits are heard in patients with hepatitis or neoplasia of the liver. Okay, so those are all about bruits. And bruits are basically swishing sounds. You hear swishing sounds that are caused by turbulent flow of blood through the blood vessels. Okay, so that was about the brutes. And with this our auscultation is complete as well. Then we move on to the percussion. Okay, so how we are going to percuss is we are going to start from the xiphisternum. Okay, so we start at the xiphisternum and we are going to percuss, and usually we will notice a tympanic note. We are moving inferiorly and we will continue to move inferiorly until we reach the symphysis pubis. Okay, so sometimes just above the symphysis pubis we will notice a suprapubic dullness, and the suprapubic dullness can be appreciated if the patient has a full urinary bladder. Okay, so next we are going to check for shifting dullness, okay, which is a sign of ascites. So for shifting dullness we are going to start at the umbilicus and move laterally. So starting at the umbilicus, we are going to appreciate a tympanic note, then we are moving laterally. So at some point we are going to hear dullness. So he does not have ascites, so his site of dullness will be way laterally. But suppose if he had ascites and we heard a dull note at this point, then next what we are going to do is we are going to ask our patient to turn over on his left side. Slowly, if you could please turn over on your left side. But we are not going to leave our finger. We are not going to lift off our finger above the abdomen, because we want to keep noticing that same point, and we are going to let him rest for 30 seconds. Then after 30 seconds, we are going to percuss at the same point where we previously heard a dull note. Okay, so now when we percuss here, we will hear a tympanic note. So the level of dullness has shifted, and this is known as a shifting dullness sign. Okay, so we can confirm it again. So how we are going to confirm it is, we are going to percuss and move towards the opposite side. So we are going to hear tympanic note throughout, and at some point again we are going to hear a dull note. Okay, so once we hear the dull note, we are again going to ask our patient to be in the supine position. So, and again we are going to let the abdomen rest for 30 seconds. After 30 seconds, if we percuss here again at the site where there was dullness, we will again appreciate that the note has changed to tympanic note. So again the level of dullness has shifted. So basically this is due to the shift of fluid in ascites. Okay, so after shifting dullness, we are going to talk about fluid fill. Okay, so to check for fluid fill, we are going to ask our patient to place his hand, his ulnar border of his hand over the abdomen and press over the midline. So this is basically to block transmission of waves through the subcutaneous tissue. And what we are going to do is, we are going to press over, we are going to palpate over two sides of the abdomen, and we are going to give a flick on one side. Suppose I am going to give a flick over the left side, okay, and then I am going to feel with my left hand. I am flicking with my right hand and feeling with my left hand. So if there is a transmission of the wave through the fluids, then we will appreciate the fluid fill with our palpating hand. Okay, so that's about the fluid fill, and this is present in patients with severe ascites or tense ascites. So okay, so that's about the fluid fill, and that's about the percussion. We are done with the percussion. Okay, so next we will talk about the palpation. Okay, we are doing palpation last because patients may present with abdominal pain, and palpation may cause discomfort. So we are going to palpate the abdomen at the end. Okay, so next under palpation we will divide palpation into superficial palpation and deep palpation. So under superficial palpation, what we are going to do is, first we are going to ask the patient if they have any pain. So suppose the patient says that they have pain over the left hypochondriac region, then we are going to palpate this left hypochondriac region last. So we are going to start at the right iliac fossa, and we want to follow a systematic scheme. The scheme can be counterclockwise, it can be clockwise, it can be zigzag, but we want to follow a systematic scheme to ensure that we palpate each region of the abdomen. So we can start at the right iliac fossa and then move systematically and palpate the left hypochondriac region last. Okay, so and throughout the palpation we want to look at the patient's face, so to notice any change in facial expression due to tenderness. Okay, so we want to look at the patient's face, and how we want to palpate is, we want to palpate with the palmar aspect of our fingers and our hand. We don't want to poke down into the abdomen. It's easy to poke down when you are standing and the patient is lying supine. But we don't want to do that. We want to palpate with the surface, palmar surface of our fingers. So how we will ensure that is, we will lean forwards and we will bend our knees. Okay, so we want to bend our knees, and then when we palpate, we will palpate with the palmar surface of our fingers. So for superficial palpation, I am only going to apply gentle pressure. I am going to palpate gently. So I am starting at the right iliac fossa, then I am moving to the right lumbar region, then the right hypochondriac, epigastric, periumbilical, hypogastric, left iliac, left lumbar, and finally the left hypochondriac, which are the site of the pain. Okay, and throughout this examination, I need to look at the patient's face. Okay, so I need to palpate and simultaneously look at the patient's face to notice any change in facial expressions. Okay, so this was all about the superficial palpation. What I am feeling for exactly is I am feeling for any superficial masses or superficial tenderness, and I am also feeling for local rise of temperature. Okay, so if I want to look specifically for local rise of temperature, it's better to palpate with the dorsum of my hands, because the dorsum of my hands are more sensitive to changes to temperature. Okay, so how I'll do that is, suppose I suspect that the patient has local rise of temperature over here, then what I'm going to do is I'm going to feel for the temperature here, and then I'm going to compare it with the contralateral side, or compare it with his chest or any body part. So I want to compare to check for local rise of temperature, and I'm going to use the dorsum of my hands. So after superficial palpation, we will move on to the deep palpation, and again the system is the same. We will start away from the site of tenderness, and we will move in a systematic way towards the site of tenderness. And again we are going to look at the patient's face, and again we are going to bend our knees. The only difference is we are going to apply firm pressure over here. So how we are going to do that is, we can use a single hand and apply firm pressure. Okay, we can use a single hand and apply firm pressure over the abdomen, or we can use two hands. If we use two hands, our upper hand will be for applying pressure and lower hand will be for palpating the abdomen and appreciating any findings. Okay, so if I start from the right iliac fossa, then I will move on to the right lumbar, right hypochondriac, and epigastric, periumbilical, hypogastric, right iliac, right lumbar, and finally the left hypochondriac. And I'm looking at the face throughout the whole time, and I'm palpating the site of pain last. Okay, so this was about the deep palpation, and while performing the deep palpation, I'm also appreciating for guarding and rigidity. Okay, so guarding is the voluntary contraction of the muscles by the patient. If they feel pain, the patient will contract his muscles if it is painful. So that one is voluntary, and guarding can be bypassed by distracting the patient. If you can distract the patient, so you will no longer appreciate guarding. But the involuntary contraction of the muscles of the abdomen is rigidity. Okay, and this one is related to, or this one is present in patients with peritonitis. Okay, so this is a significant finding, and usually the patients have peritonitis, those patients will have rigidity. Okay, so another thing that I'm going to look for is rebound tenderness. Okay, so how I'm going to look for it is, I'm going to look at the patient's face the whole time. I'm going to press over the abdomen, and then I'm going to swiftly but gently lift up my hand. So, and I'm going to notice any changes in facial expression. I'm going to notice any tenderness. So that is about the rebound tenderness, and this is also a sign of peritonitis. Okay, so next I will palpate the liver, kidney and spleen. Okay, so first for the liver, the concept is that we want the inferior border of the liver. So the liver has a sharp inferior border. So we want that inferior border to lift our fingers. We don't want to go look for the liver. We want the liver to come and touch our fingers. Okay, so we know that the liver moves with respiration. During inspiration, it moves inferiorly. So we want to palpate and we want to feel during inspiration, and we want to move our fingers superiorly by 1 centimeter during expiration to look for the liver. Okay, so we move during expiration, feel during inspiration. Okay, so and how we position our fingers for this is, we want to place our fingers lateral to the rectus abdominis muscle. So there's a rectus abdominis muscle on the abdomen, anterior aspect of the abdomen. So we will place our fingers lateral to it. So our fingers will be parallel to the right costal margin. So we will feel for the right costal margin and place our fingers parallel to it. Then we are going to start at the right iliac fossa. Okay. So now I am going to ask our patient to take long and deep regular breaths. Continue to take long and deep regular breaths. Okay, so during expiration I am moving, and while it is inspiring I am feeling. Okay, so I am moving during expiration, feeling during inspiration. Okay, so I could not feel the liver in our patient, but suppose I did. Okay, suppose I felt his liver somewhere here. Then what I am going to do is, with the permission of the patient, I am going to place a mark. Is that okay? Okay, so I am going to place a mark over the point where I palpated the liver in the mid-clavicular line. Okay, so I am going to make a mark here, and then this is the site where I palpated the liver. So next, what I am going to do is, I am going to report where I palpated the liver with a measuring tape. Okay, so what I am going to do is, I am going to use the measuring tape, and I am going to measure the distance from the right costal margin. Okay, so we have the right costal margin there. So if I measure it, this distance is 5 centimeters below the right costal margin in the mid-clavicular line. Okay, so next I am going to look for the liver span. Okay, so to do that I need to know the upper border of the liver, and I am going to appreciate the upper border with the help of percussion. Okay, how I am going to do it is, if you could pull up your shirt slightly. Okay, so I am going to check for the sternal angle. So I am palpating the sternal angle, then I am moving one intercostal space below it. So this is the second one. I am moving downwards in the right mid-clavicular line. Okay, so yeah, here I can appreciate dullness. Okay, so I am going to make a mark here as well. So, and then I am going to measure the distance between these 2 points, which are the upper and lower border of the liver. Okay, so if I measure the distance, it's about 14 centimeters. Okay, so that will be the liver span. Okay, so I will report that the liver was palpated 5 centimeters below the right costal margin in the mid-clavicular line, that the liver span was 14 centimeters, and then I am going to again palpate the liver and look at his face to appreciate tenderness over the liver. Then I am going to report about the surface of the liver, whether the surface is smooth or is it irregular or nodular, and then I am going to report about the consistency of the liver. Is the liver soft? Is it firm? And then I am also going to report about the inferior border of the liver. Okay, is it regular or irregular? And I am also going to say that the liver was moving with respiration. So those are all of the things that I am going to report about the liver. Next I am going to move on to the spleen. Okay, so for the spleen I am going to again start at the right iliac fossa, because even though the spleen lies on the left side, it will enlarge and move diagonally. If it enlarges, it will enlarge towards the right iliac fossa diagonally. Okay, so I am going to apply a similar technique to palpate the spleen. I am going to palpate along with respiratory movement. So I am going to ask him to take long deep breaths. So I am going to move during expiration and feel during inspiration. Okay, so I am moving 1 centimeter at a time. So once I reach the left costal margin, I am going to feel throughout the costal margin. So if you could please continue breathing. So I am going to feel throughout the left costal margin, because the lower tip of the spleen can be present anywhere. Okay, so I did not feel the spleen. So next what I am going to do is I am going to change the position of the patient. Okay, so I am going to ask him to turn over towards his right side. Okay, so this is the position, and I am going to hold his rib cage on the left side firmly with my left hand, and I'm going to repeat the same process with my right hand. So I'm going to start at the right iliac fossa. Okay. So and I'm going to ask him to take long deep breaths. Okay. Again I'm moving 1 centimeters at a time, and similarly I'm going to palpate throughout the costal margin and correspondingly with respiration. Okay. So that is how I'm going to feel for the spleen. So you can lie supine again. Okay. So this was about the spleen. Now next comes the kidney. Okay. So for the kidney, for the right kidney, what I'm going to do is I'm going to perform the bimanual palpation of the kidney. Okay. So how I'm going to do that is I'm going to place my left hand over his back. It should be, you can lie supine. I'm going to place my left hand over his back, and I'm going to place my left hand just below the 12th rib. Okay. And my right hand will be over the anterior abdomen, and I'm going to press my left hand upwards and my right hand downwards. Left hand upwards and right hand downwards. I'm going to ask him to take deep breaths. So during his deep breaths, I'm going to feel for the inferior pole of the kidney. Okay, so if I can palpate the kidney this way, that will be known as bimanual palpation of the kidney. Okay, so and if I can palpate the kidney, then what I'll try to do is I'll try to push the kidney with my right hand and feel it with my left hand, and again push the kidney with my left hand and feel it with my right hand. So that will be known as balloting of the kidney. Okay, so that is about the balloting and bimanual palpation of the kidney. So I am going to repeat it again over the left side. Over the left side, what I am going to do is my left hand will be on the anterior aspect of the abdomen. My right hand will be over his back, just below his 12th rib. Again, I am going to press my two hands together, ask him to take long deep breaths, and I am going to feel for the inferior pole of the kidney, which is the bimanual palpation. And if I can feel it, again I am going to ballot it between my two hands. Okay. So we are done with the kidney. So after this, there are some specific point tenderness signs. The first one I am going to talk about is the McBurney's point. So the McBurney's point lies 1/3 of the way from the anterior superior iliac spine to the umbilicus. Okay, so if we draw a line from the anterior superior iliac spine, if you could come a little closer, from the anterior superior iliac spine to the umbilicus, if we draw a line, then 1/3 of the way from the anterior superior iliac spine to the umbilicus, here is the McBurney's point, and tenderness at this specific point is specific for acute appendicitis. Okay, so next one will be the Murphy's sign. Okay, so Murphy's sign, what we will do is we will place our thumb just medial to the tip of 9th costal cartilage, but lateral to the rectus abdominis muscle, and our fingers will be over the rib cage, and we will ask the patient to take long deep breaths. Notice that my finger is just above the skin, not pressing down yet. So I am going to ask the patient to take long deep breaths, and I am going to hold my finger just above that point. Then if you could please. Okay, so once he takes a few breaths, I am going to press down. Okay, so now I am pressing down, and I am going to notice any changes in his respiratory pattern. Okay, so if the patient has acute cholecystitis, then after I press my finger down, there will be a catch during the inspiratory phase of his respiration. Okay, that is because I will be touching the gallbladder, the inflamed gallbladder, and that will lead to a catch in his respiratory pattern. Okay, so next we will talk about the renal angle tenderness, or the Murphy's punch sign. Okay, so for that I will request our patient to sit. I am going to palpate at the renal angle, which is the angle made by the 12th rib and the erector spinae muscles. Okay, so here is the 12th rib, and this way lies the erector spinae muscle. First I am going to palpate here with my hands to appreciate any gross tenderness or severe tenderness. Then if there is no tenderness, I am going to give a thud with the ulnar aspect of my fist. Okay, I am going to repeat it again on the other side. I am going to palpate for gross tenderness, then give a firm thud. Okay, so that is all about the renal angle tenderness. So now we are done with palpation. Okay, so after this we have completed the inspection, auscultation, percussion and palpation. Okay, so now finally I am going to show you a sign known as the succussion splash. Okay, how we can do the succussion splash. So basically we are listening for a splashing noise over the epigastrium, and this is caused by the presence of fluid as well as gas in the stomach. So in patients with pyloric stenosis, gastric outlet obstruction, there is accumulation of fluid as well as gas in the stomach, and this will lead to a sign known as Percussion splash. So how we are going to do it is, I am going to take the stethoscope and I am going to auscultate with the diaphragm over the epigastrium. Okay, so I am going to hold the stethoscope with my 2 thumbs. Okay, so I am using 2 thumbs to hold the stethoscope. Then I am going to shake the patient's abdomen. So during this shaking motion, I will look for splashing sounds. Okay, so that was about the succussion splash. Okay, finally, before we complete the examination of the abdomen and GI system, we need to look for hernias. So next, we also need to examine the external genitalia of the patient, and we also need to perform the rectal examination, inspection as well as digital rectal examination. Only after we perform all of this, our examination of the GI system and abdomen is complete. Okay, so after we have completed all of this, we need to thank our very cooperative patient, and we need to thank all of our students. So we are thanking all of our students for listening, all of our enthusiastic students, and also the cameraman for all of his hard work. Okay, thank you.